Thank you very much, Ernest, for that introduction. And thank you to Chin and Rahul for the invite today. So guys, I'm going to talk to you a little bit about some FRCS tips and tricks. And I'm focusing really on the Viva part 2 of the exam. So, is it right? Right, that's it. So these are my declarations. So I'd run Let's Talk Doctor. Now, there are many different ways to skin a cat, and I could probably give you an all-day talk about tips and tricks, but I'm going to focus really on just a few today. So first of all, I want to dispel the myths about this mystical exam that we all as trainees fear and build up in our heads for about 6 years, and tell you about knowledge. So the first thing we say is that knowledge is the most important thing. I'm here to tell you that actually knowledge is not the most important thing. You have to have some knowledge, but actually technique is incredibly important. The FRCS Viva is difficult. So I would argue that actually the FRCS Viva is one of the easiest exams you will ever take in your entire life, because it is all you have been doing for 6 years. The questions are entirely predictable and they are repetitive. So actually, if you keep it simple, it's a very simple exam. If you make it complex, it can be a very difficult exam. I'm here to tell you that the FRCS is not an exam. Now, you might say, what has he had in his drink at lunchtime? Of course it's an exam. We pay £2,000 to do it. I'm here to tell you it's not an exam, it's a job interview. They are testing you as a day one consultant colleague who they are potentially going to be working alongside in the future. So you've got to go into it with the psychology of talking to a colleague rather than talking to a senior. So today I'm going to focus really in on 3 topics or 3 tips and tricks. Compartmentalization, the use of 3 words or buzzwords, anticipation and guidance, and then give you a little bit of a structure for how to tackle tricky questions called the 5 Ds, okay? As I say, there's many different ways to skin a cat. I'm just giving you a few little tips and tricks that you can talk through. So first of all, compartmentalization. What do we mean by that? Well, compartmentalization is about structuring things so that they're in an easily digestible form. So I'll tell you about my fellowship. I went to Australia in 2017, and I had some time in a shoulder hospital, and I did some elective surgery, some trauma surgery, spent some time at the beach, went to see some good sports, had some nice food, met some good friends, saw some beautiful aspects of the culture, and it really helped me going forward. Now, the content of that is probably quite interesting, but the way it's delivered is so boring. I can see the guy back there is completely falling asleep. So actually, if we can compartmentalize that and say, during my fellowship in Australia, I discovered 3 things about myself, spiritually, psychologically, and socially, which changed me as a surgeon and a person for the better. Immediately, I've drawn the audience in. Physically, this, this, and this. Psychologically, this, and this. And socially, this, and this. So what you're doing there is compartmentalizing your knowledge for the examiner so it's easily digestible. And then you're signposting them the way to go. And actually, compartmentalization is a very key skill which we use on a day-to-day throughout life. Even as a consultant, you go into meetings where you're asking for finances. I want finance for this because I think it can help patient safety, it can be more cost effective, and it gives a better experience for staff and patients. That's compartmentalization. So I'm going to give you some examples of that just in sort of context. And I'm going to talk through these just for the sake of time. So let's imagine this, a 50-year-old gentleman who comes off a ladder at approximately 5 feet, okay? What's our big concern here? Does any of the trainees just want to shout out? What's your big concern? 50-year-old, 5 feet, fallen off a ladder. It's an isolated injury, ATLS is done. Any concerns about that fracture pattern? Correct, right. So what they're testing is, are you going to be a safe day one consultant and mention the fact that this could be pathological, bisphosphonates or cancer, and do that first before you go on and nail it? And if you were going to go and nail this, is this a technically easy nail to do? What things might you be concerned about? So with these subtroch fractures, the proximal fragment is often flexed up, so you may have a low threshold to open, and also they can go into varus, so you may go for a more medial entry point than normal. And then obviously post-op, you have to worry about, let's say they're on bisphosphonates, osteoprotective medication. So if I was going to compartmentalize this question, I'd probably divide it into my immediate management in A&E and excluding a pathological fracture, my technical tips of nailing, and then post-operatively, osteoprotective medication or strategies for that. Something like this, 25-year-old who comes off a bicycle. What's your big concern when you see something like this? Okay, but then following that, let's say you've checked the neurovascular status and you've reduced it. What else can you see here that might give you a bit of concern? If I can see. What's that? So potentially there's a bony fragment. Could it be coming from the coronoid? Could it be coming from the radial head? So the issue here, the buzzword is stability. And that's what you're concerned about. So if I was going to break this up, I'd probably talk about my immediate management in A&E, checking the neurovascular status, check for compartment syndrome, splint it and reduce it, and then get appropriate radiographs. Then my determination of whether this is a stable or an unstable fracture, CT, and talking through stabilizers of the elbow, according to O'Driscoll. And then finally, my operative management, which could be about the surgical approach and fixation techniques. So I've compartmentalized that for the examiner. And by stating that and being quite aggressive with your signposting within the first 30, 40 seconds, immediately you've put them at ease because they're like, well, this candidate, he or she knows what they're talking about. Again, something like this, a 25-year-old medico-legal barrister, it's always a medico-legal barrister in the exam, has come off their motorbike and sustained this injury, closed, ATLS is done. What's your big concern about this? Is that normal? I know we're at a knee meeting, but probably doesn't look quite right, does it? Yeah? Median nerve, isn't it? So this is a perilunate dislocation. So again, what's your compartmentalization going to be here? Well, it'll be our immediate care in A&E, check the median nerve, maybe have a go at reduction under adequate sedation and muscle relaxant. Do we take it to theatre or not? And if we do, how do we do a closed reduction? Of course it's going to fail in FRCS, so then how do you do an open reduction and definitive fixation? So that is going to be our way how we compartmentalize it. So you might say to me, and I'm going to move this on, how do you compartmentalize something? Because Rishi, you've given your way of doing it, but how can we compartmentalize it ourselves? Because ultimately, I want to give you guys some tips and tricks to take away. Well, you can start with chronology. Pre-op, intra-op, and post-op is a very easy way to divide something up. You can talk about etiology. Why do hips dislocate? Patient factors, implant factors, surgeon factors. And finally, anatomical site. So I give you an ulnar nerve palsy, a claw hand. Is it a high or is it a low palsy? So these are classical ways that you can compartmentalize things for the exam. I'm going to just take you through a very quick fire round, and all I'm going to focus on here is subdividing up a topic. So how do antibiotics work? Okay, a very dry topic, something we don't really want to answer. But you could say they work on the cell wall, the proteins, the 30 and 50S ribosomes, and the nucleic acids. Nice, easy way of dividing them up. How do you prevent thromboembolism in neck of femur patients? Well, you could do pre-op, intra-op, and post-op, or you could be a bit more interesting and say, well, actually, thromboembolism occurs because of Virchow's triad. It occurs with problems with flow, constituents, and wall. So I can do things which act on the flow, adequate hydration. I can do things which act on the constituents, anticoagulants. Or I can do things which act on the wall, making sure I do adequate soft tissue handling, etc. All right, so it's a nice way of dividing things up. You've got a difficult colleague who's come in. How would you break that up? Well, classic structure from ST3 interviews, SPIES, situation, patient safety, initiate something, escalate as appropriately, and then offer them support. These are classic ways that you can divide things up by compartmentalization. So the next thing I want to talk about is buzzwords. And it's amazing, guys, how 5 minutes goes incredibly quickly in the vivas. And so I always say to people, you've got to cut down the words that you are saying and be concise. Every single thing that comes out of your mouth effectively needs to score a mark. And so there's a reason why the number 3 is often used in political speeches. Strong and stable, get Brexit done. Because this is a number that's actually been shown to be very effective in people's brains for getting things stuck in. So I always say, if you can look at a picture and describe it in buzzwords or buzz phrases, you will massively cut down the amount that you can say or need to say. So, can anybody give a shout out, spot diagnosis there? What does that show? Anybody know what that is at all? Yeah, so you said Paget's, didn't you? Yeah. So, if I wanted to give some buzzwords for Paget's before I say the word Paget's, I call this technique teasing or titillating the examiner, all right? So let's give about 10 seconds of sexy buzzwords to draw them in before I say the word Paget's hip OA. You could say there's loss of corticomedullary differentiation. There is a coxavera or a shepherd's crook deformity, as well as reduced joint space, osteophyte formation, subchondral sclerosis, and cysts. This is Paget's hip osteoarthritis. I'm not even looking at the picture, all right? I've got the diagnosis, and I'm going to give the buzzwords to match the diagnosis. Okay? Spot diagnosis, 6-month-old child? DDH, all right. But before we say the word DDH, again, let's do a little bit of teasing of the examiner. So, first thing you could say is, you've got a small ossific nucleus. If you cross the Hilgen-Reiners through the triradiate cartilage and the Perkins lines, you've got a head sitting in the upper outer quadrant. You've got an increased acetabular index, and you've got a broken Shenton's line. This is DDH. Okay, 4 key buzzwords, and I've literally passed the station within the first 30 seconds because that examiner knows that I know my stuff just by being concise in what I'm saying. Okay, diagnosis. Oh shit, is that the diagnosis? What would you do what do you think this looks like? So this is what we call a radial club hand, okay? It's a longitudinal defect because of something going wrong on the ulnar to radial growth. But if I was going to give some buzzwords for this, before I jump in and say the word radial club hand, I'd say there's a shortened forearm, there's radial deviation, and there's an absent or hypoplastic thumb with a scar indicating recurrent or resistant radial club hand. Again, I've said that in my opening gambit of about 20 seconds. 15-year-old playing football comes off the pitch. What's the diagnosis? Right. Now, I know in the exam, the next 3 questions the examiner is going to ask me are, what are the 3 planes? What is the Salter Harris? And why does this occur? I know that's where it's going. So why not bring that into your opening gambit? This is an AP and lateral radiograph of the ankle in a skeletally mature individual. On the AP, I can see a Salter Harris 3 fracture, which is a sagittal plane fracture. On the lateral, I can see a Salter Harris 2, which is a coronal plane fracture, making a Salter Harris 4 in total. This is a triplane fracture, which is a transitional fracture caused by differential closure of the physis. Okay, that's 30 seconds, and I've already passed that station. Now I'm on to checking the neurovascular status, getting a CT, and planning definitive treatment. The entire case will be done within about a minute. And I'm not rushing. But what I'm doing is I'm coming down to pertinent points. I'm not wasting time. I'm not wasting words. Okay, fine. So I'm just going to hurry it along with it. The last technique I want to teach you guys is about anticipation and guidance. Now, I always think there's 2 ways of answering a question in FRCS. One is called pitter-patter, which is where the examiner will say something to you and you will say something back. 1-word answers, lots of prompting, and you're never really going to score more than a 6. Or there's another one called anticipation and guidance, which is where you know exactly where that viva is going and you take them there. Okay? So it's a little bit like having a good date and a bad date. Pitter-patter is really like a very boring date. It's not going anywhere. Anticipation and guidance is, you know exactly where it's going. You drive that conversation on, okay? So this patient here, DEXA scan, okay? So rather than thinking forward, I start at the end and I work backwards. So I know with a DEXA scan, the last question is going to be, how do bisphosphonates work? I know that. So then the question is, well, how do I get from DEXA scan to how do bisphosphonates work? Well, first of all, a DEXA scan. It's dual energy X-ray absorptiometry, 2 X-ray beams, different intensities for the hip and the lumbar spine to calculate bone mineral density. Okay, what is it used for? Bone mineral density to work out fracture risk assessment score, T-score, Z-score, used for osteoporosis, WHO definition. How do we treat it? Nice guidelines. Final question, how do bisphosphonates work? Okay, there's no other way that question's going. I got this in my exam and they let me talk for 4 minutes, 57 seconds. Okay, you know where it's going, so take them there. Something like a perilunate dislocation. The last question is going to be, what do you do with the median nerve? It's not working anymore. So start in A&E, okay? Galula's lines, ATLS, reducing it, checking the median nerve. Do I take it in the middle of the night or not? If I do a close reduction, decompress the carpal tunnel. It's FRCS, it doesn't reduce. Okay, now we do an open reduction, definitive fixation. They come back 6 months down the line, the median nerve is still not working, tendon transfers. There's no other way that question is going to go. Okay, they're very predictable. So it's important when you learn for this exam that you remember the scoring system. Now, I've probably been a bit facetious by writing that, but actually it is quite hard to score a 4. All right, so the majority of us are going to be in this 5, 6, 7 group. And basically, I want you guys to try and aim for the 7s and 8s, and that way you'll score as highly as possible. And the way to do that is your opening gambit and remembering the timing target. So I want to give you a structure to take away today to help you to progress through the exam. And this structure is called the 5 Ds of Deer. With any FRCS question, you will usually be given a picture or an X-ray, and it's important in the first 20, 30 seconds, describe it. This is an AP and lateral radiograph, or this is a clinical photograph, it shows. This is an explanted specimen of a tibia, it shows. And when you describe it, don't just describe what you can superficially see, but describe it in terms of higher order thinking. So don't just say this is a valgus knee. Talk about there is a hypoplastic lateral femoral condyle. Is it sublux because the MCL may not be intact? Is there bone loss from the proximal tibia? Because that shows the examiner that this candidate understands they may need augments. So that's higher order thinking that I'm bringing into my description. Diagnosis, come to the diagnosis within 30 seconds max, okay? Discussion. Discussion are what are your concerns about this case and how would you address them in terms of history, examination, and investigations. So I kind of think of this as imagine you're driving along in America and you've got the pot of gold at the end of the rainbow, which is your 8. Okay, you're driving along Route 66. You've got the shit on the side of the roads, your history, your examination, your investigations. You want to acknowledge the shit, but you don't want to get stuck in it. So you have to have a way of progressing through that quickly. And that's what compartmentalization and signposting comes in. These are my concerns, and this is how I would address them in terms of clinical, biochemical, and radiographic assessment. Decide. You've got to come decision making. You've got to be in theatre by 2.5 minutes if you want to score a 7 or an 8. This is a surgical exam. We need to get there in correct time. Diagram. If it's a basic science station, draw a diagram. Detective is evidence and debate or discussion point. That's usually where you're going. I'll just finish one last thing, sorry. So I'm going to just literally give you guys an example of the 5 Ds of Deer, just to take away. So let's think of something like this, okay? We can see obviously that this is a Sufi, but describe, let's describe it in terms of buzzwords. This is a limited AP radiograph which shows disruption of Klein's line or a positive Trethowan sign. The epiphysis is then located, but the metaphysis has displaced. This is a Sufi, and it's probably a moderate to severe Sufi. So that's describe and diagnose. Now, how do I get through the next 2.5 minutes without wasting time? The history, the examination, the investigations. I tell the examiner my concern. I want to address the patient clinically, biochemically, and radiologically to determine stability, severity, chronicity, and involvement of the other side. Stability, can they weight bear or not? Do they have any history of growth hormone deficiency or hypothyroidism? Do I need to fix the other side? Okay. On examination, do they have obligate external rotation? Check their biochemical markers and get further imaging like a cross-table lateral. Decision making, 5 threads to cross the physis, anterior in the neck, center in the head, and finally, debate. There's 3 controversies. Do you prophylactically fix the other side? Do you reduce or fix in situ? Or do you do early or late? Okay, guys? So to conclude, you've got to lead your viva to score big. Try and enlighten and dominate the examiner if possible. I don't mean that in an aggressive way. I mean that in terms of taking it forward. Don't be aggressive. Even if the examiner is wrong and you know they are wrong, that's an argument you cannot lose. Sorry, you cannot win, I mean. And you've got to know the rules. Always stay in shallow waters. Start simple and then go complex. They are testing your ability as a safe day one consultant, not a specialist. Listen to the question, don't argue. And you can pass or recant, but just once or twice. Okay? Take a leap of faith, don't be afraid. Okay? And if you've got any questions, That's the thing that I can get behind. Okay.
Thank you so much, Rishi, for that. We're just going to open the floor for about 5 minutes of questions. Yeah. Anyone got any questions?
Well, my only observation is I have been an examiner in the past, and there are times when you'll be with an examiner who isn't that knowledgeable.
Sorry,
In my experience of having been an examiner in the past, there are occasionally times when you recognise examiners who aren't that knowledgeable. They are quite vulnerable. And if you come in as this kind of candidate, they are going to be left without questions to ask. You're taking the rug from underneath their feet. You have to be quite careful and read how far you're going to score an 8 every time, because you might find the examiner is really struggling a bit, and they're going to come up with their really difficult questions because they recognise you're the kind of candidate they've got to push down a little bit so they can keep control of the interview. So that's just my observation. I mean, you are incredibly articulate and very knowledgeable. It's overpowering what you said, but I know some of my examiners would also find you overpowering as a candidate, and they would struggle.
So what I would say to that is, and I think that's a very good point, I would say that obviously I've shortened things a little bit just for the sake of time, but within those subheadings you can develop things. So you still have to, and that would be my thing, you have to tick off the basics before you go complex. So for example, let's say I said that, look, I wanted to address the triplane fracture. So on a clinical assessment, I would take a history. I would ask about the nature of the injury. I'd ask about the timing. I'd want to examine them for their neurovascular status. This is what I would check. So you can build detail into that. And so what I would probably do is, part of this is I'm giving you the structure for the next few minutes, and you may not release all the structure straight away, but you'll have it as a kind of skeleton in your head. But I would say that exactly. So if you thought it was an exam where they wanted to take you a little bit more slowly, then I would just expand on those certain things. But I think having those timing targets in your head, it just helps you to bring the conversation along, because I've seen people who they'll spend about 2.5, 3 minutes and they're asking irrelevant questions. But I agree with you. I think you can't jump in and go straight for the 8. You have to tick it off first and start simple first. But I would say ask relevant questions and not irrelevant stuff, basically. So, but no, I think it's a very good point. Thank you.
Thanks very much, Rishi. So just starting to revise, do you have any tips on structuring your revision? There's so many topics, so what are your thoughts on that?
So I would normally say, first of all, timing, and I think it's a very personal thing. So people have personal circumstances. I would normally say work backwards from your Part 2 exam by about 9 to 12 months. So normally I say 6 to 9 months for Part 1, another 3 months for Part 2. And then I said about things like clinical stuff, I tried to learn within the job. So whenever I was seeing patients in clinic, I always asked the boss, can I please see 2 new patients per clinic? And what I would do is I wouldn't read the letter, and I would actually say to the patients, look, I'm going for my exam, can I time it on my iPhone? 5 minutes history, 5 minutes exam, and then 5 minutes discussion. And it actually has 2 effects. Number one, it gets you taking a history in that time and knowing what 5 minutes feels like. But number 2, it makes sure the patient doesn't waffle, so you actually get through your clinic a bit quicker. So that's one thing. Learn clinical stuff within the job itself. Things like basic science. I try and make basic science part of my life. It's incredibly boring to learn if you make it as a separate thing. So whenever I was in an operation, if I was assisting that ST3 and I was getting a bit bored of doing a hemi and holding a retractor, I'd be thinking, okay, why is that scrub nurse mixing? What are they mixing? They're mixing a liquid monomer, a powdered polymer. Okay, they're mixing in a vacuum. Why am I pressurizing? What's that stuff, laminar flow? How does it work? So everything I would try and incorporate into my job. And then I would just structure it into different topics. So peds, hands, adult path, and I would make a very structured revision plan, schedule, and stick to it, basically. But reward yourself. You do need rewards. You can't go hell for leather for 9 to 12 months. It's not possible. So that's kind of how I'd probably start with it. Oh,
sorry, just thank you. Ties in a bit with the first question, really. It's about technique. And do you think there is a place for pausing in your answer?
Absolutely.
Instead of waiting for the next question to be asked? So you give your buzzwords and then...
Absolutely. And listen, as I say, today, I mean, because it's a trim talk, I've kind of said things a bit quick and it can sound a little bit overwhelming, but sometimes, as I said, pitter-patter, you have something which is very open-ended and you don't know which way it's going to go. So if I showed you a picture of a knee replacement and I just showed osteolysis, okay, let's say something like that, that could go down an infective route, it could go down an aseptic loosening route. So I would probably describe what I can see on the x-rays, and I'd say, look, my concerns are about the possibility of aseptic loosening or infection. So in order to make a diagnosis, I need to assess the patient clinically, biochemically, and radiographically. And I'd pause, and I may let the examiner then give me some information back. And they might say, well, okay, are there any criteria you know? Well, I know about the MSIS criteria. Pause. Can you tell? So every time I say a sentence, and I know I'm speaking a bit quickly now for time, I give a pause, and that's to allow the person to invite in. So as you said before, so it's not quite so overwhelming and intimidating. So it is more like a conversation. So you'd say something, and what I tend to do is I tend to throw carrots. So when I say something, I will tend to throw a carrot, which is inviting the next question. And they may not take that invitation, but I might say, I would diagnose an PJI according to certain criteria. Pause. Okay, I know the next question is going to be, tell me about those criteria. Does that make sense? So, but
how do you deal with the pause? Do you hold your nerve, or do you
you
carry on?
Just pause as you would in a conversation for about 3 seconds. And if the examiner doesn't, sometimes, and I did that in mine, they didn't want to stop you. So they were like, okay, he or she knows what they're talking about. And I go, well, some of these criteria are this, this, this. So this is what I would do. But it's just giving that invitation for the person opposite you to be able to interject, basically.
So,
I think we have time for just one last question.
yeah. So I got a lot of respect for Rishi. Rishi was my mentor. My name is Mr. Shiv Prakash. I'm one of the consultant orthopedic surgeons in Darren Valley. The key thing about exam for me is practice, practice, practice. So I would highly recommend you guys to go to the hospital, elective center, and practice with a buddy 5 minutes of your timings. And for every viva question, take a paper and start drawing it. Draw whatever you want to draw relevant to that particular question so that you buy time, and thereby you'll be concentrating on your diagram, and in the meantime you're answering the question as well. So Rishi was my mentor. I passed the first time because of him, and I got great amount of respect for him. Thank you.
Thank you.
Guys, one comment as well, just to support that. It's the same. I did Rishi's course now, I don't know how long ago, 5, 6 years ago. And yeah, unbelievable technique and organization towards how to answer the questions. So, you know, for trainees out there, if you want to do an FRCS course, please consider his one. Really recommend it.
Thank you. Thank you.